as well as, of course, our WHO Director, Dr. Teresa Kasayeva, who will open this event. We have a member of our civil society task force to provide perspective, and we would like to keep this meeting as interactive as possible. So we would like to welcome and urge you to join us in every activity. This meeting is also being live streamed on YouTube using the Global TB program channel. My colleagues will put the link on the chat in case anybody is interested, and the recording and presentations will be made available on the WHO webpage on the internet. So before we begin and we go into opening, we can see that we have over 80 participants connected. And we welcome you. Thank you for joining us on a Friday. We know that these are difficult times, busy times. We'd like to know who you are. So before we go into the opening remarks, very quickly, if you could share, we see that you're very interested in the WHO guidelines, in the work that WHO does, and that you are engaged in guideline development. So if you could go on slido.com. So my colleague has just shared. So if you could use your phone to quickly scan the QR code, and it will take you to a link. Or you could go to www.slido.com and type in the passcode #InfoCS. So if you could go there, please, that would be great. So maybe ask you to do that. So E, if you could start the first one, please. So we would like to know who is connected. And of course, we can see participants, the names and who it is, but we'd like to know what role you play as civil society and other partners in the WHO TB guideline development and process. So if you could log in to Slido and let us know. Okay, so it's good to see who's joined. So we have people, members who have been part of the development process. Good to know. GDGs review. People who are working with countries to support uptake. All right. Capacity building, information sharing, community and civil society engagement, resource mobilization, good, 15%. So this is just to quickly understand who is with us and your roles and your interests. So yes, so 53%. So the majority of you are working with countries or as part of country programs to support uptake of guidelines. Many of you, a large proportion also, wow, it keeps changing. Yeah, a lot of awareness building through information sharing, capacity building, that's great. So you do a lot of training, a lot of advocacy. Also, some proportion are involved in the GDGs and review and in community and civil society engagement, and a small proportion on resource mobilization. So thank you. So thank you for sharing. We welcome all of you on board. We are very appreciative of your constant support, and we look forward to interacting with you through this session. Please do stay connected. So without further ado, if we could go back now to the main session, E. Okay, I'd like to now invite our director, Dr. Teresa Kasayeva, the director of WHO's Global Tuberculosis Program, to warmly welcome the members of this information session. Teresa, the floor is yours.
So thank you very much. Dear colleagues and friends, good morning, good afternoon, good evening. It's a real pleasure to address you virtually today at the WHO information session for civil society and community representatives on updates of WHO TB guidelines development. This meeting is part of our regular dialogue with the civil society representatives. And despite the challenges posed by the COVID-19 pandemic, we are glad to meet you to share the latest information on WHO TB guidelines development, and in particular to hear your feedback. Civil society continues to contribute to the WHO TB policies and guidance, catalyzing growing collaboration between civil society organizations, national TB programs, and the WHO, as well as engaging in advocacy at all the levels, including highest levels. Last 2 years have been hard. I can't, on behalf of GTO Global Tuberculosis Program, appreciate your hard work and contribution. And now we know that you are supporting to combat not only with TB, but also with COVID-19. COVID-19 pandemic has led to huge losses of human life and prosperity worldwide, posing an unprecedented change to public health. The economic and social disruptions caused by the pandemic are devastating. Tens of millions of people are at risk of falling into extreme poverty, and the number of undernourished people has increased. We know that the COVID-19 reversed the progress towards global TB targets. 2021 Global TB report shows that for the first time in over a decade, there was an increase in tuberculosis death. Tuberculosis is the world's second top infection of COVID-19, claiming close to 4,100 lives a day. Approximately 1.5 million people died from TB in 2020, almost double that number who died of HIV, AIDS, and remaining major contributor into the death of people with HIV. This is precisely why our joint efforts are more important than ever. Year 2022 is around the corner, which is of course the year of our hopes and continuing fight against diseases, and also year of the UN high-level meeting targets. Accelerated efforts in areas such as multi-sectoral engagement, accountability can be powerful in catching up losses in progress to end TB and to continue further progress for those who continue suffering and dying from this preventable and curable disease. We need communities and groups of civil society to come together, meaningfully engaged, particularly at country levels, to help accelerate the recovery from the health and non-health effects of the pandemic. We count on you to raise the visibility of realities that the person affected by TB and their families are facing, and to request concrete actions to accelerate and strengthen the TB response. You can count on our full support and engagement. And it's extremely important you to be fully aware about latest development of the guidelines. Believe me, we have much better opportunities to provide successful diagnosis and treatment for patients with TB. And with your support, we can make these opportunities and uptake of the guidelines faster and more effective. Thank you again for your time, and I look forward to the discussion today.
Thank you so much, Dr. Kasaeva, for your inspiring opening remarks and for setting the stage for this important information session. So dear colleagues, so we see that we now are at 100 participants. Thank you again for joining us. Just to reiterate that we would like to keep this session as interactive as possible. You will hear, following this, you will hear presentations from several colleagues or staff or experts of the WHO Global Tuberculosis Program and from the Civil Society Task Force. We urge you to use the Q&A function if you have questions on or clarifications on specific presentations. These will be responded to online. So before we go right into the presentations, we'd like to take this opportunity to do a very quick quiz with all of you to gauge your understanding of the guideline development process. Maybe you are very well versed with how things operate at WHO, but this is just, we can call it an icebreaker. And the top 3 winners will receive a special gift from the World Health Organization Global TB Program. So we will mail it to you at the end of this quiz. So something exciting on Friday. So I will ask my colleague now to share the quiz. Again, this is a quiz on Slido. It's a very simple quiz. So if we could go back to the start. Okay, so please join the quiz. Again, very simple. Please scan the code using your mobile phone, or you can join us on slido.com with the password hashtag info.cs. You can see I'm connected. I can see colleagues connected. Paran, Gunta, Roger, Christina, Anirudh. Okay, keep going, everyone. We'd like to have a good bunch. Come on, please log in. Okay, so waiting for a few more. We have over 100 connected. Please log in. Right, good to see more names joining. Martin, Jamal, Florence, Nina, Kaimar, Lara, David, Ezio. Okay, our staff Avinash. Yeah, and we promise that we'll try not to win it ourselves. So, okay, let's try and cross at least 40, everyone. So 40 people joining at least from the group. So please do log in. I'll give you one more minute for people to log in. Either scan the QR code and go to the link, or www.slido.com and put in the password hashtag info_CS. Okay, we are at 38. We just need 2 more people to connect. Okay, 1 more person to connect. We have 39 people connected. All right, we're at 40. So now, so people can join the quiz as we go along. The QR code is visible. Okay, we're at 42, very nice. Okay, just 2 more seconds and we will go in. So let's start the quiz. Okay, so the first question, all of these are time limited, so you have 30 seconds to respond. How much time does WHO take to develop guidelines from the availability of new evidence? Option 1 is 6 to 12 months after detailed review, 1 month, 2 years, or 3 years. Time is running out, so you need to pick quickly. Okay. Wow. All right. So most of you have got it correct. So if you could go 1 step ahead, E. Yes, so the correct answer is 6 to 12 months after detailed review of evidence. A rapid communication is normally issued earlier, much earlier in the process. And as my colleague Matteo Ziniol, the unit head of the Policy, Care and Innovations unit, who is also here and leading this work, will let you know, it is quite a detailed process. It's not just consultations within a guideline development group, it's scoping, it's identification of questions, preparation, bringing the evidence together, detailed review. So all of this does take time, but it's done as quickly as possible. There is rapid communication issued, so people have the information and can proceed to act. Next question, please. Okay, so let's see. Oh, okay, we have 5 top winners leading. So we have Donna, Andrea, Avinash, Asta, and Gilles. So well done. So keep the momentum going, guys. We want you to win as well. We're rooting for you. Next, please. So how are WHO guideline development group members selected? You have 30 seconds for this. So the first option is a systematic selection process based on criteria, including expertise, gender, geography. Experts are selected based on the number of scientific publications. Experts are selected based on financial contributions. So top guesses for which would be the correct one. Okay, time's up. Well, we're very pleased to see that majority of you, 92% of you got it right. Whoever selected financial contribution, we can assure you that's definitely not the case. And the 5% about scientific publications, that is not all of the criteria. It is probably taken under consideration as one of the tiny criteria, but it's not the only criteria. Can we move ahead, please? Let's see who's leading on this. Okay, so Andrea's jumped to top slot, Donna down, and then Avinash, Asta, and Gilles. So let's go to the next question. Okay, so are members of affected communities and civil society part of guideline development groups, which is a group that helps provide inputs to recommendations that are developed by WHO? Yes, no, or is it sometimes as needed? Okay, time's up. So if we could go to the next and see what the answer is. So the correct answer is yes. Yes, they are included. It's not sometimes as needed, but systematically members of affected community and civil society over the past few years have been engaged in guideline development groups. Okay, next one, please. Okay, so we still have the same leaders. Avinash has dropped down. So we have Andrea and Donna leading with Gilles, and then Asta. Next, please. So does WHO manage conflict of interest in the guideline development process? So this is often a question that's asked about conflict of interest or influence on the development process. How is it done? Is it yes, WHO staff check reputation and skill of GDG experts through a quick Google search? Or yes, experts and advisors complete detailed declaration of interest forms before the meeting, which is assessed by WHO and legal if required? Or is the answer no, no review of interest is undertaken? Okay, let's see who has responded to this. Wow, okay. Again, majority of you have it right. There is a very strong process in place to review conflict of interest, to stop undue influence on WHO guideline and recommendation development. It's done with great detail, including legal if necessary, and declaration of interests are often read out. It's not just a simple Google search that staff do here to figure out if it's okay or not. Okay, let's go to the next one, please. Okay, again, Donna has now come to number 1. Well done, Donna. Okay, Andrea, Asta, Gilles. The others, please try and catch up. You can definitely get on the leaderboard. Oh, and Lindsay has joined. Great. Great. So next, please. So what constitutes conflict of interest for WHO that precludes participation in developing recommendations? So this would mean this conflict, any of these conflicts would mean that they cannot participate in guideline development groups. Owning shares in a company that manufactures a product or technology that may be recommended for use in the guideline, or hold a patent on a product or technology that may be recommended for use. Having a family member who works for a company that manufactures a product or technology, all or receiving funding or being employed by in multiple ways, including as advisors, speakers, opinion leaders for a company linked to the guidelines that are being developed, current or past involvement in a major academic program that's contributed to the research on the guidelines being developed. Yeah, that's being considered for a recommendation. Great, time's up. So let's see what we have. Okay, again, great responses. The correct answer is yes. All of those constitute serious conflicts of interest for WHO that would preclude participation of the applicant in the guideline development group meeting. Let's go to the next one, please. Okay, so we have Asta climbing up and Lindsay climbing up, and Donna still holds the top spot. So you can see that people can get in. So please, let's look at the next questions that are coming up. We just have 3 more to go. So what is the validity of WHO guidelines? Is it 5 years, 10 years? Are they living guidelines with rapid updates as required, or just 2 years? So yeah. What is the validity? How long do guidelines last or are applicable for? So we have 8 seconds left for this response. Great, and now let's see what people are responding. Again, 80% have it correct. In recent years, our guidelines are really living guidelines. WHO publishes rapid updates based on new evidence coming in or new technologies that are coming in. So this is very much, our enhanced guideline process. Let's go to the next one and see the leaderboard. Oh, okay, we missed the leaderboard there. It's okay. Let's go on. We have 2 more questions. What additional tools does the Global TB program develop and provide to support guideline uptake? Operational guides, digital tools, webinars, rapid communications, country support and discussions, all or the WHO TB knowledge sharing platform, which you will hear about next. So let's see. Okay, all of you have it correct. It is all indeed. Let's move ahead. Okay, Donna's on top still with Asta, Lindsay, Andrea, and Gilles. Great, well done. Let's go ahead. Is it the last one? Yes. So does WHO support rollout of guidelines in countries? Is it no, this is the responsibility of countries and partners? We just do development, or is it yes, WHO works with countries and partners, including civil society, to support rollout? Or is it sometimes, perhaps, depending on if we have financing available, that WHO supports rollout? Okay, so this is the final question. Let's see how everyone has done. The answer is indeed yes. We work with countries and partners, including civil society, very extensively to support rollout. So let's go ahead and now see what the final score is. So the winner of the quiz is Donna. Congratulations. Please do send us your address on the chat, your full name and address. Also, congratulations, Asta, Lindsay, Gilles, and Stin. Oh, you've suddenly jumped in at the last bit, and it also shows us which was the hardest question, which interestingly is linked to why we are having this information session about civil society and communities being part of the guideline development group process. So congratulations to all 5 of you. Please send us your names and addresses, and we look forward to sending you your gifts. So let's now move on from the quiz. Thanks to all the nearly 50 people we had participating. Thank you very much for joining the quiz. Let's now go to the next part, which is really the detailed presentations. So we'd like to start with what we mentioned as one of the tools to support the guideline development, the guideline uptake process, which is WHO's newly released TB knowledge sharing platform. And we're very pleased to have with us Dr. Avinash Kanchar, who is part of the TB Prevention, Care and Innovations Unit at the WHO Global TB Program. So Avinash, grateful if you could present on the knowledge sharing platform.
Yeah, thank you very much. Monica, please confirm if you see my screen and if you hear me well.
Yes, can hear you clearly. If you could just go on presentation mode, we can see your slides.
Is this working? Do you see my slides?
We can see, but it's not on presentation mode yet. And now it's gone to your other screen. Okay, now it's fine. Please proceed.
Presentation mode? Yeah, okay. Thank you very much. So as Monica mentioned, this is the new tool that we have launched recently. And I'm happy to present. And I'll start by highlighting few of the challenges that we have heard from countries as well as implementers, and particularly the members of the civil society that were challenging in terms of availability or access to the WHO guidelines in the past. And this included the issues like the guidance being dispersed across different documents, and that the implementation guidance was not always published along with the guidelines themselves. The presentation styles were not uniform across the guidelines. And often the outdated guidance remain online and along with the latest guidelines, and that was causing confusion. E-learning tools or training material was also not available in many cases. Also, there were specific requests, like particularly for members from the civil society, for example, they may have interest across the different guidelines, but only parts and sections of those guidelines. And it was not easy to have access to different sections spread across different guidelines. So to address these issues, we developed this platform called TB Knowledge Sharing Platform, and it was launched in June this year. And this platform is designed to be a one-stop shop to access all the latest WHO guidelines released by Global TB Program. It provides several resources to facilitate rapid uptake. The guidelines themselves have been consolidated, so you'll have one consolidated guidelines for screening, for example. And along with that, the implementation guidance is developed at the same time and is available and could be accessed from this platform. There is also link to the individual recommendations, and if you are interested in knowing more about what went behind a recommendation, what was the evidence that was reviewed, what were the discussions that happened during the guideline meetings, so all of that can be accessed through this platform. There is a quick search feature which enables you to quickly find the recommendation you're looking for, or recommendation for a particular population that you're looking for. And also, we are currently finalizing the training material, at least for the first three modules, and we are hoping to have at least one of them out this year, and most probably by the first quarter you'll have all the three available. So you can see three big boxes at the bottom of this slide, in three colors, and that's where you can access the consolidated guidelines, handbooks, and the training catalog in future. So just to take you briefly through the menu of things on this platform, and at the top of the screen you can see consolidated guidelines highlighted in blue. And this is what you'll find on this page. You'll have the latest guidelines in modular form. So we have 4 modules right now: TB prevention, screening, diagnostics, and treatment. And along with that, other relevant guidelines are also placed. Like for prevention, we have the latest infection prevention and control guidelines. And on the right side, you can see the operational handbooks, which are aligned to these guidelines. If you continue to scroll across the top of your screen, the menu, soon you'll have the training catalog populated here as well. Next is a feature for quick search that I mentioned. So you could search by keywords, or you could search by key populations that you are interested in, and all the relevant content could be listed at as you can see on the screen. And then you can these are clickable links, and you can go and check the details. As I mentioned, you can have access to details of every individual recommendation through this feature. This is a link to a platform which serves as a repository of all latest WHO recommendations, and they are also categorized according to the modules: prevention, screening, diagnosis, treatment, and comorbidities. And you can see the number of recommendations under each of them. There is also a search function within this screen, and you can look for a particular recommendation for a specific population or for a particular age group. And then once you are on a recommendation, you can find all the details that are listed on the bottom of the screen, starting from the strength of the recommendation, certainty of the evidence, to the evidence summaries, as well as evidence to decision tables. So all of this content can be accessed through this one window. And there could be also a cross tabulation of these recommendations by different populations. For example, for people living with HIV, you could have all the recommendations relevant to PL-HIV across. For example, in this case, you see screening recommendations for PL-HIV, and there are 6 of them, and you could click on in any of these tabs, and you could have the list of all the relevant recommendations that you see on the right. And finally, a feature that you may find useful. There is also a PDF viewer within the platform, and this PDF viewer allows you to bookmark specific pages in a guideline, and then you can put together these pages in your personal space, and you can download and print them. So it can be across different guidelines, and you can have your own document in PDF form and downloadable. And all of this is available on a mobile platform as well, along with a few additional features like algorithms and dose calculators for in this. If you can see on the page for TPT here, and we will continue to populate these additional tools, which are very useful for implementation. So I'll stop by acknowledging Dennis Felsen, who has steered this work, and all the colleagues from the WHO regional offices and country offices and other partners. Thank you.
Thank you very much, Avinash, for an excellent presentation. My colleague Dennis has pasted the links to what Avinash just shared to the knowledge sharing platform, as well as to download the apps on your phone. So as you can see, as Avinash presented, you have guidelines at your fingertips, very easy to refer to, no longer having these big documents that you have to flip through to find to find key information. So moving on with the time. So thank you, Avinash. That was an excellent presentation. I'd now like to turn to my colleague, Saskia Denboon, to go on next to share with us about the new guidelines on TB screening, systematic screening for TB disease. The floor is yours, Saskia. We can see your presentation clearly.
Okay, in full screen. Okay, thanks, Monica. So yes, I would like to give an update on the screening guidelines that were. Let me just move to the next. Oops. Yeah, here we go. So I'd like to present on the guidelines for systematic screening for TB disease. These guidelines were released in March of this year on World TB Day. And these guidelines were updating previous guidelines from 2013. This update reflects new evidence on the effects of screening, new developments in screening tools for different populations. We have, for the first time, for example, recommendations on computer-aided detection and artificial intelligence for the automatic reading of digital chest X-rays, and new evidence on the performance of screening tools. So these guidelines are available on the knowledge sharing platform that Avinash has just presented, but can also still be downloaded in PDF format from the WHO website. So I'll briefly go through the recommendations. Most of you will probably be familiar with it since they've been out for a while. But we have the recommendations divided in two groups. We have recommendations on populations to be screened and recommendations on tools to be used in these populations. So with regard to populations, there are 4 groups in which screening is strongly recommended. And these are household and close contacts of TB patients, people living with HIV, minors, and prisoners. Additionally, screening is also conditionally recommended in the following populations: people with untreated fibrotic lesions, people with clinical risk factors in moderate prevalence settings, which is defined as 100 per 100,000. And that would include, the clinical risk factors would include, for example, people who are malnourished or people with diabetes. Screening is also recommended for communities with increased risk of TB and limited access to care. And there we can think about, for example, the urban poor, homeless people, refugees, migrants, and other vulnerable or marginalized groups. And lastly, screening in a general population is now also recommended in settings with a TB prevalence of 500 per 100,000 or 0.5%. In the screening guidelines, several new screening tests were recommended. Well, chest X-ray was already there, but it's continued to be recommended as a highly sensitive screening tool. And one of the big advantages is that it detects TB, or it can detect TB prior to the onset of symptoms. It's recommended for almost all populations, including people living with HIV and child contacts. And I already just briefly mentioned that we now, for the first time, recommendation on the use of computer-aided detection software using artificial intelligence to interpret digital chest X-rays. And that can be used as a possible alternative to human readers. CAD can be used for screening and triage for TB in adults aged 15 years and older, including people living with HIV. Another new screening test is the molecular WHO-approved rapid diagnostic test, or short acronym, oops, am I going too fast? MWRD. And these are recommended for all people, including people living with HIV. And I specifically want to highlight that they also recommended as a test and treat strategy for inpatients with HIV in high burden settings. And the last new test to be recommended is a C-reactive protein, or CRP, which is specifically for people living with HIV. Came out as a very good screening tool and recommended by WHO as an additional option for screening in this population. After the guideline update, we also updated or adapted the Prevent TB app to include TB screening. This app was initially built to facilitate the evaluation of contacts for TB preventive treatment and can be used by healthcare workers in a variety of settings. So it can be used for contact tracing, but also for screening of other high-risk groups. The app is free and can be downloaded from the WHO website. It can be adapted to country-specific context and the cascade of care. Different languages can be adapted to different languages, and is also compatible with DHIS2 and other electronic data systems. Then we have the Screenscreen TB app. This app was originally designed in 2013 to help programs select or at least get some insight in the choosing different populations and screening tests and algorithms, and to see how this impacts on the yield and the efficiency of screening. We've made some modifications on the app, but we still need to make further modifications to the app in 2022 to fully reflect the changes to the guidelines that we made this year. Also want to highlight with regard to CAD, the Global TB program worked with TDR to develop a CAD calibration toolkit, which allows the implementers to calibrate CAD to the local setting and use case where it's intended to be used. So this includes a data collection protocol and a web-based tool that can assist with the analysis of data and calculations of a specific range of thresholds, and then the sensitivity and specificity across these thresholds. And then finally, my last slide, the TB screening guidelines were developed on the independent evaluation of 3 CAD softwares that were available at the time. And since then, a lot of new software has become available. And we know that countries and implementers sometimes have a lot of questions about which CAD software to choose. So we have other partners find, in collaboration with the Stop TB Partnership, they have provided a landscape of CAD software, which gives an overview of available products and their characteristics. But Global TB Program is now working also with the pre-qualifications team in WHO to set up a system of pre-qualification of CAD software. Pre-qualification of CAD software should help with quality assurance and also with product selection for procurers of the software. So this was in brief the highlights, the sort of main changes and the main recommendations on new populations and tests for TB screening, and some of the derivative products that have become available and that we are in the process of developing, and that will continue into 2022. Thanks, Monica. Oh, you're muted, Monica.
Sorry. Thank you, Saskia. That was really a deep dive into the screening guidelines and all the latest developments. Thank you for sharing. Thank you also to all those who are using the Q&A function to post any questions. If you have questions and clarifications, a reminder, use the Q&A button and you will have responses online. So I'd now like to turn to the next panelist, Nazir Ismail, again from the Prevention, Care and Innovation team at the Global TB Program. Nazir, could you please take us through the latest guidelines and the developments on diagnosis, please? Over to you, Nazir.
Thanks a lot, Monica, and good morning, good afternoon, good evening to everyone. Let me just get up my slides. Can you confirm it's full screen and you can hear me?
Yes, full screen and we can hear you. Please proceed.
Okay, fantastic. Okay, right. So let's get straight into it. This is an update on the TB guidelines for 2021 and plans for 2022. So despite the COVID epidemic, we have been quite busy on the diagnostic side. And I think many of our other teams as well have been quite active. For 2021, we had planned 2 GDGs, and for 2022, 2 as well. The first one in green highlighted on top is what has been concluded, and I'll speak to that in the next slides about the outcomes of that guideline development group meeting and the guidelines that were updated this year on several new classes of tests. We had planned a second GDG on novel sort of MTB specific antigen test, skin test for TB infection. That was planned for November 2021, and there were some issues related to the data and further analysis that was required. So that's moved into early 2022 in orange there. So that's in progress, and I'll speak to that also a bit later on. And the revised dates are now 31 January till the 3rd of Feb to conclude that work, at least in terms of the guideline development. But I noticed that the informed audience is aware that it takes 6 to 12 months for the full process to conclude. And then the other guidelines that we're planning is one on the LF-LAM assays, the second generation, and last is around next-gen sequencing. But to start off and just highlight what's happened in 2021, we've updated the consolidated guidelines following the GDG on nucleic acid amplification tests, and 3 new product classes were added to the new guidelines, providing more options for countries, but also addressing important gaps that existed. Just to note that there's one new initial test for diagnosis. So while we had expert and TrueNet, a new class has now been added, which is the moderate complexity automated nets. And these detect not only TB and resistance to rifampicin, but also INH, so that's upfront INH testing. And then there were 2 follow-on diagnostic tests that have been added, and I'll speak to those, but important developments in resistance detection for follow-on tests after TB has been confirmed. So the first, as I mentioned, is the moderate complexity assays. These are now recommended for patients with signs and symptoms of TB as an initial test. But currently, the recommendations are limited to patients with pulmonary TB and therefore respiratory samples, and should be used for the detection of pulmonary TB and also upfront detection of RUF and INH. The extrapolations were done for people living with HIV and for adolescents and children, but not for extrapulmonary TB. Just for people's information, in terms of the moderate complexity class of tests, there were 4 products that were included in this analysis, and some of them are quite familiar to, I think, audiences in the HIV world as well. So the Big Abbott and Roche systems are included in the moderate complexity assays. A new product from BD, which is the BD Max, and the Bruker-Hain systems have moved on to a new platform. And what you'll notice from all these technologies is that they are higher volume capacity instrumentation with relatively fast results for higher throughput. But they are moderate complexity, meaning they really need to be lab-based, right? It requires a functional sample referral system. The next class of technologies that are recommended are what we call the low complexity automated nets. The first in class here is the Expert XDR cartridge, so complementing what we already have with Expert and Expert Ultra. So there was a positive recommendation for its use. Important to recognize this is a follow-on test, so its recommendation is for bacteriologically confirmed pulmonary TB, so a follow-on test essentially. But importantly, it simultaneously detects resistance to 4 drugs. And the recommendation here is for testing of all TB, so that's rifampicin susceptible and rifampicin resistant TB for the detection of INH and fluoroquinolones. We know that's becoming increasingly relevant for rifampicin susceptible TB. And then it also detects resistance to ethionamide and amikacin, but the recommendation in those cases pragmatically obviously related to rifampicin resistant TB. The recommendations are extrapolated to other populations, including adolescents and children, people living with HIV. And in this case, the extrapolation was also for extrapulmonary TB, recognizing the performance of this platform for extrapulmonary TB as well. And the third class of product that is now recommended is a first-in-class assay, which is a GenoScholar PZ8 TB, a first molecular test for pyrazinamide, We know parazenamide is widely used in many first and second line regimens, and this is the first molecular test. However, the recommendation is only on culture isolates at this stage, and that was based on the available evidence that we had. The performance was reasonably good, and there's a conditional recommendation for its use as such, but really opens up a way forward for molecular testing for parazenamide. So moving on, so that's what's completed. Moving on to the next item on our plans. It indicated this GDG on MTB antigen-based skin test for TB, for the diagnosis of TB infection had been postponed to January, end of January, beginning of February. This is a class-based recommendation as well, and we're evaluating 4 different products. 3 of them are based on the ESET6 and CFP10 antigens and come from manufactured in different settings. So the ones from produced in India, second from the Russian Federation, the third and fourth from China. So new set of competitive products in the TB infection space, and these are skin tests. So I mean, a major advancement from what we have is the tuberculin skin test. I think that's exceptionally old now. But really it has the advantage of being specific as they use TB-specific antigens. Thus far, we've completed 4 preparatory webinars and heading towards now the final GDG in just over 2 months' time. The final reports are expected later today, and we'll be reviewing that and assessing that and then provide it to the GDG members. We aim to, following the meeting, we aim to have a rapid communication by March and then have the guidelines out 3 to 4 months later. Just bear in mind that we're planning to include now a submodule on TB infection within the diagnostic space, so that's something new as well. But we're aiming to have it as an infection to diagnosis, infection to disease handbook as such. And then the other 2, so I won't spend too much time on them. So these are planned, but as is with all GDGs, it's really dependent on the evidence available. So the first GDG planned is on the 2nd generation LF-LAM assays for the diagnosis of TB. And this, the first-in-class product here is a Silvamp, which is the Fujifilm product on the LF-LAM. There's many studies actually underway assessing this technology. There has been some switches on the type of technology being used in terms of cost reductions in a version 1, version 2. And that bridging study has not yet started. So from what we understand, that could happen quite rapidly, but there were some issues around variability of V1 results that were being investigated. And we're closely following up. So we tentatively plan for Q3. But until we get a clear idea of when bridging study will be completed, it's difficult for us to confidently confirm Q3. However, I mean, we need to plan. So we've already set up a steering committee, drafted the PICOs, and identified systematic review teams in preparation, but all dependent on the final outcome from Fuji. The last one planned for 2022 is on next-gen sequencing for the diagnosis of drug-resistant TB. We're planning for that for the late Q4, but depending on the evidence, again, it may get pushed into Q1 2023. The technology is here, so although there is a lot of sequencing going on, it's often whole genome sequencing and not targeted that can be done on direct specimens, and there are now end-to-end solutions being developed and evaluated. So there's 3, DeepLex is the one system, DeepCheck, a US company, and then Oxford Nanopore's got their product as well. So there's currently a FIND-supported multi-country clinical trial underway. We expect to receive results by Q3 2022. The earlier delays, I mean, this supposed to have happened earlier, but there were a lot of delays related to the COVID impact on the clinical trial startup. But I think those have now slowly improved. There are other small operational research studies also on these TNGS studies, and then the systematic review will consider all of that. Yeah, so that's basically a quick roundup of 2021 and 2022's plans. Yeah, thank you.
Thank you so much, Nazir. So it's good to have this detailed overview, and also thank you for sharing what the plans and developments are looking ahead to 2022. Reminder to participants to please post any questions you may have using the Q&A function. As you can see, these are being responded to rapidly by our staff. I'd now like to turn to the next presenter, Lynn Yan from, again, from the Global TB Program Prevention Care Innovation team to share with us about updates on TB treatment guidelines. Over to you, Lynn. The floor is yours.
Thank you very much, Monica. Can you confirm that you can see my slides in full screen?
Yes, we can, and we can hear you loud and clear. Please go ahead.
Thank you very much. So I will, on behalf of the treatment team, to present to you about the updates on TB treatment guidelines and handbooks. And before to start with the new developments, I want to present to you in this slide all the guidelines on TB treatment that have been released by WHO in the last over 2 decades. And also very important to note that since the year 2010, WHO update guideline development methods. So the guidelines after this year, 2010, are more evidence-based than the ones released in the previous year. That's more based on expert opinion. And on the upper part of the slide, you can see all the guidelines on treatment of drug-susceptible TB. And the 2 guidelines that are important is the version in 2010 and another update in 2017 that include many valid recommendations that are still implemented until now. And the team in GTB is in the process to consolidate and update the TB treatment guideline for the STB in 2021 and 2022. And I will present in more detail in the next slides. In the lower part of the slides include all the guidelines on treatment of drugs-resistant TB. And you can see together with some handbooks that help with more details on implementation aspects of the treatment. And the last guidelines you can see is issued in 2020 that the consolidated guidelines that include all the valid recommendations in the previous version in 2011 and 2016, and together with the handbook. So the new developments in 2021 and 2022 about guidelines that for the STB guidelines, we are in process of consolidating and updating guideline with a guideline group meeting in earlier this year. And the new update will include very important news and information about the shortening treatment regimen with 4 months regimen using rifampicin and quinolone. And that will be another option in addition to 6-month regimen that we've been using for many years. And the launch of this guideline is expected in around Q1 next year. Regarding drug-resistant TB guidelines, we are in process of preparation for the update of the guideline that expected in 2022 with the new evidence on some regimen, especially shorter regimen with own oral for treatment of MDR or rifampicin-resistant TB, including 6-month and 9-month regimen. And the guideline group plan to review new evidence on the BPAN regimen, that 6-month regimen, including 3 medicine, bedaquiline, ritonavir, and linezolid. And also the new data from the TB practical trial that has the new regimen, BPAN plus moxifloxacin for 6 to 9 months. And in addition, there's also data from a systematic review on drug-resistant TB and hepatitis C prevalence and co-administration of this treatment for these 2 diseases. And the GDG meeting date is planned in February and March next year. And the launch of the new guideline update is expected in Q4 2022. So together with the update of the guidelines, the handbooks is also updated. And for the drug susceptible TB, the new handbook is under development because we did not have the handbook for the STB in the past. And this handbook also planned to be launched in Q1 2022. And this document will include information on selection of treatment regimen, dosing of medicine that's used in treatment for the STB, and all other implementation aspects. For drug-resistant TB, the handbook also updated in 2022, and the launching timeline also the same with the guideline in Q4 next year. And that also include all the update information on the implementation of different regimens for drug-resistant TB. So in addition, there's some other normative documents in relation to treatment. WHO also updated definition of treatment outcomes and definition of pre-XDR, XDR, and XDR TB that released earlier this year in 2021. And that will be included in the upcoming update of the framework for definition and reporting for TB. And also very important that we are in the process, in the final step on the development of the DRTB training models that is planned to be released very soon, maybe later this month. And another important update that will be happening next year or maybe the early 2023 is about updated target TB treatment regimen profiles that will be happening. And the last development is quite important for the updating policy on DRTB treatment is about individual patient database platform. This IPD platform is very useful for updating WHO guidelines on DRTB treatment over the last years. And the purpose of the IPD is to facilitate pooling of individual patient data on ERTB treatment that contributed by researcher and programs, and also facilitate policy development and public health research. There's some rearrangement happened this year that allow clear link of the IPD with WHO and allow regular public calls for data and allow direct access to data analysis for development of guidelines and more flexibility in data review team selection, and also allow open access to external researchers. So the new data curator has been selected for this IPD, and we are in the process of transferring the all the data sets from the former data curator, that's McGill University in Canada, to the new curators, that's the University College London, that's based in London, UK. And some other the work in progress to append the data set collected from the public call for data in 2021 by WHO. And there's some ongoing discussion to include pediatric data in the IPD as well, and also how to include data from randomized controlled trials, and setting up the oversight committees and that allow the researcher to assess the data for public health research. So I stop here, and hopefully we'll have a lot of exciting updates next year to report to you from all the process that presented.
Thank you so much, Lynn. That was a very clear presentation. You took us through the evolution of the guidance and the critical developments, and ended with the data sharing platform. So thank you for that comprehensive overview. Again, please do ask questions using the Q&A function. Our colleagues will respond. I'd now like to turn to my colleague from the Vulnerable Communities, Comorbidities, and Civil Society team, Kerry Viney, who will provide us an update on what guidelines are expected on the issue of vulnerable populations, comorbidities, ethics, human rights, and social protection. Over to you, Kerry.
Great, thank you, Monica. And can I just confirm that you can see the slides in the right view and you can hear me? Yes, I can see you.
Thank you.
Thanks very much. So hello, everyone, and good morning, good afternoon, and good evening. I hope you're doing well, and thank you for joining this information session. As Monica mentioned, I'm going to talk about updates in the areas of vulnerable populations, notably children and adolescents, and comorbidities, as well as ethics, human rights, and social protection. So firstly, thinking about children and adolescents, as you may know, the current guidelines for the national TB programs on the management of TB in children were issued by WHO in 2014. So it's the red document you can see on the right. So we had a guideline development group meeting in May, June this year to update those guidelines. That guideline development group meeting did involve civil society, and I think the person is on the call today, so thank you for joining. Now, the evidence that we looked at for these guidelines was structured around 6 main research questions. You can see those research questions there: integrated treatment decision algorithms, the use of expert ultra in gastric aspirate and stool, treatment shortening in children with non-severe TB, the use of bedaquiline and delaminid for the treatment of multi-drug resistant TB, a shorter regimen for the treatment of TB meningitis, and also models of care for both case detection and the provision of TPT. We also looked at a couple of background questions on the socioeconomic impact of TB on children, adolescents and their families. And we also had a question about how to optimally engage adolescents in their own TB care. We also had some contextual information which provided background information for the guidelines. So after this guideline development group meeting, which was held in May, June this year, we issued a rapid communication. We heard earlier from Monica during the quiz that we are issuing these rapid communications to rapidly disseminate the information from guideline development group meetings. So that was published in August, and this document outlines the main questions that were addressed by the guideline development group, the findings from the trials and reviews that were used to answer the questions. And it also outlines the main updates that will be published in the upcoming guidelines on the management of TB in children and adolescents. It is important to note that the rapid communication really signals what to come in the guidelines, and that comprehensive information on the recommendations themselves and also implementation guidance will come out in the form of a guideline and an operational handbook. Now, as mentioned, we are in the process of finalising the guidelines on the management of TB in children and adolescents and an associated operational handbook. So the guidelines will consolidate the new recommendations that were made in May, June, as well as other existing recommendations that are relevant to children and adolescents in one guideline. And the operational handbook, of course, will include practical implementation guidance. We did hold 2 additional consultation meetings after the guideline development group meeting, one on the classification of intrathoracic TB disease and another one on dosing for bedaquiline, delamanid and the shorter TB meningitis regimen. And those information from both of those consultations will also be incorporated into the operational handbook. Now, as I mentioned, we released the rapid communication in August 2021. It does signal some key updates that will be published in the guidelines in early 2022. And this slide just really summarises those key updates. So one of the first key updates is that Expert Ultra will now be recommended for gastric aspirate or stool samples in children. And this is in addition to sputum and nasopharyngeal aspirate, which are already recommended by WHO in the guidelines that Nazia spoke about. So all 4 specimens will be able to be used with Expert Ultra. Then in children with presumptive pulmonary tuberculosis who are attending healthcare facilities, there'll be an interim recommendation on the use of treatment decision algorithms to diagnose pulmonary TB, which is really a structured approach using signs, symptoms, radiology to come to a diagnosis in children. Then in children and adolescents with presumed drug-susceptible TB meningitis, a 6-month intensive regimen composed of isoniazid, rifampicin, pyrazinamide and ethionamide will be recommended as an alternative option to the current 12-month regimen. Then there is a 4-month treatment regimen that will be recommended for children and adolescents with non-severe TB. And that will, of course, be an alternative to the 6-month regimen. Then for the treatment of drug-resistant TB in particular, all oral treatment regimens containing bedaquiline will be able to be recommended in children below 6 years of age. So effectively that removes the age limit for bedaquiline. And similarly for delamanid, there'll be a recommendation about the use of delamanid as part of longer regimens for children below 3 years of age. So again, removing that age limit there. Then there will be updates on models of care, specifically for decentralised TB services for children and adolescents with signs and symptoms of TB, and family-centred integrated services, which were both found to increase case detection and also the provision of preventive treatment. Now, just thinking about comorbidities now, in particular HIV infection. So the Global TB Program did contribute to updated HIV consolidated guidelines, which were published in July this year, the blue and white document that you can see there on the right. There is a new recommendation on when to start antiretroviral treatment among people with drug-susceptible TB. And you can see the recommendation here on the screen. So it is that ART should be started as soon as possible and within 2 weeks of initiating TB treatment, regardless of the CD4 cell count among people living with HIV. So this replaces the previous recommendation, which recommended starting ART within 2 weeks, but only among people with CD4 counts of less than 50. So now this applies to everyone regardless of their CD4 cell count. And then thinking a bit more broadly of comorbidities in general, the Global TB Program is currently preparing a framework for collaborative action on TB and comorbidities. And the goal really is to decrease the joint burden of TB and comorbidities with a view to aligning with the WHO NTB strategy targets, as well as the UN high-level meeting commitments on TB, non-communicable diseases, HIV, and universal health coverage, which have been held over the last 5 years. This framework is in the process of being developed. It will provide a structure and suggested mechanisms for establishing and strengthening collaborative action on TB and comorbidities, of course, across disease programs and also the relevant sectors outside the health system, to really ensure the delivery of evidence-based and people-centered care for people with TB or at risk of TB and with comorbidities. And of course, the overall aim is to decrease morbidity and mortality among these groups. This document will build upon the success of the WHO policy on TB-HIV collaborative activities and really recognises the large burden of TB attributable to comorbidities and health-related risk factors such as undernutrition, diabetes mellitus, cigarette smoking, alcohol use disorders, and others. So that document is in the process of being developed at the moment. Then in terms of future plans for the release of WHO guidance, so as I mentioned, the consolidated guidelines on the management of TB in children and adolescents are at a very advanced stage, and they will be published in early 2022. We are also in the process of consolidating our TB and HIV recommendations. Again, that will be published as consolidated guidelines on the management of tuberculosis and HIV, and they will also be published in early 2022. We are also working on associated operational handbooks, which contain implementation guidance. So they will be published alongside the guidelines. And as I mentioned, we are currently developing our WHO framework for collaborative action on TB and comorbidities, and that will also be published in early 2022. We are also currently reviewing evidence on TB and other comorbidities apart from HIV, as well as interventions among vulnerable populations, to prepare for reviews of WHO guidance in 2022 and 2023. So that is scoping work to prepare for the next few years. And we will also be developing training materials on child and adolescent TB, and that work will start in 2022 with other training materials to follow. And then finally, this is my last slide. So just to talk about some of the other work on equity, ethics, and human rights. And this work is being led by Dr. Ernesto Jamarillo in the Global TB Program. So WHO is planning to release consolidated guidelines on ethics, equity, and human rights in the context of the implementation of the NTB strategy, which will be published in 2022 as well. We're also working on guidance on social protection, and this will be published as consolidated guidelines on integrating social protection into TB services in the context of the multi-sectoral accountability framework, again scheduled for 2022. And I think quite exciting that we're looking at a future publication of consolidated guidelines on tuberculosis and disability, looking at prevention and rehabilitation of disabilities among TB survivors, which will likely be published in 2023. And alongside these guideline documents, we will be developing training materials on ethics, equity, and human rights next year. There will be future publication of operational handbooks associated with this guidance. And finally, for all of the documents that I've spoken about in this presentation, we will be disseminating them in the next 2 years through WHO webinars. All of the recommendations will go onto the knowledge sharing platform, which Avinash spoke about, and then we'll be disseminating this information through various fora, including global, regional, and country meetings throughout 2022, and of course beyond. So I'd just like to thank you for your attention and welcome any questions. Thanks very much.
Thank you very much, Kerry, for that excellent presentation. You really took us through the whole scope of the extensive work being done on, from childhood TB to comorbidities to ethics, human rights, and ethics. So a lot of great work happening, which will come into light in the coming months. So thank you for that. Again, a reminder, please do post your questions in the Q&A function. I'd now like to turn to our final presenter, but very important presenter, Ezio Tavora, who is a member of WHO's Civil Society Task Force, and he also leads a lot of civil society led work in Brazil and other countries. So thank you, Ezio, for joining us, and we look forward to hearing from you, Ezio, on how civil society and communities can contribute to WHO guideline development as well as uptake. So the floor is yours, my friend.
Thank you, Monica. Actually, the communities have been contributing a lot in the last years. I hope, I don't know how this, do you see my full screen or not?
Yes.
Yeah.
Perfect.
The first thing that I would like to say is that not only as a CSTF member, but somebody who has been working in civil society engagement in TB research since 2007, I think we have to salute the accelerated process that WHO has been implemented to revise the guidelines and to have the inclusion of communities. But the community engagement and the contribution for WHO guidelines development happens in two ways, directly and indirectly, I would say. Directly, we could mention the participation in the GDG meetings of community representatives. We have been having, I would say, an average 2, sometimes 3 civil society participants at the GDGs since 2019. This is a progress considering before that year. And we also have CSTF members participating in the GDG. There was an agreement that was discussed since 2018 that we should improve the GDG civil society participation, obviously with people with more skills, to follow up and to discuss the themes of the GDG, but it's important to highlight several aspects, which has to do indirectly with the capacity. So I would start saying that there is a lot of progress. I mean, there was increased participation of communities. This cannot be denied, and discussion among the networks of what I just said, which is the participation on who is skilled enough or who should represent communities in the different GDGs. So the selection of those with engagement in different areas of research or policies is fundamental, but that requires a series of aspects. I would also mention the openness of WHO to discuss the composition and participation. And we have a language, I would say, that's I mentioned by language the fact that we are revising in the GDG discussions the terminology that we use. So WHO has been improving in terms of using terms which are more appropriated from the perspective of communities. For example, not calling people in treatment or vulnerable populations or trial participants as patients, because they are not patients. They are patients to their physicians. I mean, they are trial participants, or they are civil society representatives, or communities affected, or a person affected, etc. So we have to use the right terminology, and WHO has been improving a lot in this concern, but we still have a long way to go. And the approaches to the themes, modern scientific, we have been also discussing in the GDGs the fact that more than scientific, we have to have an approach regarding policy and person-centered approaches, like what are the needs of people affected. One thing that we have been intensively discussing is the fact that every clinical study should have a component, obligatorily, I think, to assess the conditions of the trial participants of those studies, so that we have data enough to report or to analyze the data under the light of the reality of those affected. We cannot accept a study being done in India and analyze quality data from Europe. I mean, it's not fair. And we should have also, although quality studies don't require a sample like quantity studies do, but we still have to have a reasonable representativeness. The challenges is the variety of the composition, the membership. So should we establish how to say, at least participation of 3 civil society representatives at each GDG? We had increased to 2 at least, so we have having that, but should we have more? I think the more we have, the better it is. But there are the challenges of the specialities, as I mentioned before. So, we have to think. I mean, there is an expectation. I still feel that a lot in the different GDGs and in the technical discussions. I have to say that the communities also have been participating intensively in the technical discussions, which also, how to say, compose or structure the GDGs discussions. So, and the communities have been participating in several opportunities on technical consultations. But we have to improve the skills among global advocates. I mean, the empowerment, the capacity building, and the research literacy has been increased by community advisory boards initiatives. But we still face language barriers and cultural aspects. And I have to mention that there is sometimes, not sometimes, often I would say, that people feel embarrassed, community reps feel embarrassed to express their views because they think like, why should I do this? I can sound stupid, or my point may not make sense for these researchers. They are all top researchers in the world in the specialities. So they feel sometimes embarrassed, and this has to do with empowerment, and this has to do with capacity building. So this requires a lot of investment in capacity building and in research literacy, which is highly needed and little achieved. I would salutate also the fact that we have incredible contributions for the discussion. Obviously the leadership of a treatment action group by means of the Global TB CAB and the CRAG, which was even before that in TB field, so to engage communities in that. And again, I would say that there is here a perspective of the big contributions that the communities are already giving indirectly by participating in studies, engaging happening. This is happening more and more. We have seen progress, and this also still have a long way to go. So the communities, by means of follow-up of studies, are contributing. I mean, we could mention many aspects that the CABs, local or specific for a study, or the Global TB CAB, or the CRAG, or many others have increased in the quality, and even in the BRICS, some BRICS studies, we have contributed with that as well. For example, to engage components, or to have it guaranteed that some community perspectives should, and we could shape the protocol in a better way. For example, with the inclusion of women, or pregnant women, or children and adolescents, and obviously HIV and AIDS in some studies where it's relevant for this population. So the communities have been not only in directly contributing to the GDGs, but by means of the CABs. But this requires a long-term investment. TB Alliance has been doing that. For example, we have also to applaud this initiative. I mean, TB Alliance have been doing this since its creation, and the stream study is an excellent example. I'm proud of participating of that. Is building a dissemination process, completely inclusive, listening and being formatted by the communities. This is beautiful. I mean, I think this will be an excellent example for the future of big clinical trials, what stream is being doing, and to count with the continuity that TB Alliance has been providing. But this is few. I mean, some of them disappeared, some of them are discontinued. And we have to have other CAB initiatives throughout the globe. I was just doing a video course to engage communities in research, and Carla from the Brazilian National CAB was talking exactly about that, and Olga Klimenko, also from Ukraine, also saying that we have to invest in that, because to have CABs independent and having people, communities empowered to participate meaningfully in the creation of the guidelines, we have to have a funding that guarantees that these CABs can run and can hire persons to be dedicated to do that work. The CABs, normally, they work on a volunteer basis, and the members work extra hours because they have to do their living, they have to work in other things, and they are not dedicated specifically to that. So it's very unfair. The community participation is very unfair. From one side, you have the researchers which has institutional background and can support. So we need direct funding for support for CE treatment and research, and direct support for the CAB initiatives. We need to increase the data collection and inclusion of questions from the community perspectives. That's it. Sorry that I took probably more time, like often. Thank you, Monica.
Not at all, Ezio. In fact, you are giving us the real practicality, what's really happening on the ground, the feeling of civil society communities. You are the real voice. So thank you for sharing those perspectives, and also your advice on, building engagement and capacity building. I think these are all very practical and much needed. So many thanks, Ezio, for your intervention. It was extremely useful. So now so many thanks to all our excellent panelists. So what we'd like to do now, as I said at the start, we'd like to keep this as interactive as possible. Many thanks to the audience. We have over 110 people who've been with us from the start. Thank you for staying on, for your many questions. As you can see, my colleagues have been responding online. So what we'd now like to do is to do a very quick, maybe a little bit of a live response to certain questions. that we'd like to curate. So please do post any questions you have using the Q&A function. So we'll take 10 minutes for that, 5 to 10 minutes to quickly respond to a few questions. And then we have a question for you. So we'll come back on that. Let me see. So if all the panelists who've just spoken, if you could turn your cameras on, that would be appreciated. Thanks. And Matteo, Teresa, everyone, thank you. So many thanks to all of you. Great. So let's start. We have a few questions online. So let me start with the chat first. So one of the concerns, multiple concerns, I would say, we can see that Paul Summerfield, Femi, Femi and Femi Adevole and Martin Van Cleef all are quite concerned and asking about WHO's role in supporting countries to uptake guidelines, now mainly looking at the new drug-susceptible TB treatment guidelines, which are coming out. So my colleagues have responded online, but we'd like to take this live a little bit for a response on what is WHO going to do, especially in the coming year, to give a big push on these guidelines, which are going to drastically change the landscape. So I'd like to start with Lynn. Maybe you'd like to start first, and then I'll turn to Matteo to add. So Lynn, would you like to give a quick response to that question, please?
Monica, sorry, you refer to the question on the publication of the WHO. Sorry, can you repeat the question?
No, so the question is on the rollout of drug-resistant TB treatment guidelines in countries. What is WHO going to do to really push or promote uptake?
All right, thank you very much. So I think from the WHO side, in headquarters level, we plan to will update the guidelines as soon as possible when the evidence becomes available. That's the first thing. And I think as the last few years, we release rapid communication to support the country to save time and prepare for the updates and roll out of the new regimen or new recommendations. And at the same time, WHO has the network at 3 levels: country, WHO office, regional office, and headquarters to support countries, especially the high burden countries, in updating national guidelines, planning for rollout of the new regimen. And also all other logistics preparation, like procurement of drugs, etc. And there's some technical assistance mechanisms available for that. Of course, WHO working with all other technical partners, and regional green light committees is one of those mechanisms to provide that kind of support. So I think in the country, the national TB programs can assess the support from IGOC and also other technical support mechanism, like I mentioned.
Thank you so much for that, Lynn. So we now have Matteo Zignol, Unit Head of the Prevention Care Innovations team. Matteo, if you could add, please.
Just a small addition to what Lynn said. I think Lynn has been very, very comprehensive. Just to say that in the sort of dissemination, implementation phase of guidelines throughout the spectrum, we need the involvement of civil society. And one of the examples, we really need that. As WHO alone, even with technical partners, we are not going to be able to ensure a prompt dissemination, the implementation of the guidelines. As Ezio also reiterated in his presentation. I give you an example, which was also on the chat. You have seen the rapid communication, and Lynn has actually already responded to that, but we have seen a rapid communication around a new regimen for drug susceptible TB, like 4-month regimen. The rapid communication is out. It was out in the summer. The guidelines will be out soon, as Lynn has presented. Now, what it takes to implement that regimen with rifampicin, where we have an issue there. The regimen is extremely costly. At the moment, it costs probably 6-7 times more than the current 6-month regimen because of rifampicin. We have an issue with availability of rifampicin, which is also affecting TB preventive therapy, as you know. So here, clearly, we have a huge bottleneck for implementation of this regimen. And we need the voice, a strong voice of civil society to really shout and say, we need a shorter regimen. It's the first time in 50 years that we've got a shorter regimen, shorter than 6 months, for the treatment of drug susceptible TB. First time in 50 years, 50. We need that. We cannot wait 5 more years because there is no rifampicin available, because the cost is too high. So we are going to do our part, I can assure you, but we need really the involvement of all of you. Over.
Thank you so much, Matteo and Lynn. Indeed, a very clear call. We need all hands on deck, especially from civil society and communities, if we want to make sure that all these guidelines that you've heard and all the updates that are coming up are able to be rapidly rolled out to reach those.
Monica, may I say a few words?
Please say a few words. Yes.
Thanks, Matteo, for what you said. But I think also this is what marks TB. What is unfortunately a mark of tuberculosis is the authoritarian, in the sense of the knowledge. Who detains the knowledge is the medical knowledge which cares. And I just did an interview a couple of weeks ago for the video course that I was, and I asked a fabulous advocate, TB advocate, who is I would say the best member of the most active member of the Simplicity CAB here in Brazil. And I asked, so what is the most difficult problem regarding TB research or engagement of community? She said, hunger. I mean, famine, because people, I mean, that's a fact. So, and we have to understand that the limitations that people have to access treatment will not be solved with only diagnostics or vaccines or new compounds. I mean, we have to tackle. That's why math is so important. That's why we have to tackle TB from other sides. But that's a fact. I mean, I would also remember that what I was saying, that tuberculosis is marked by how to say, lack of priority or lack of speed comparing to HIV and AIDS. So the advocates were always jumping to require or to request that new diagnostic method would be implemented, that people would have access to the new drugs, et cetera, and had a very good area to implement new AIDS vaccines, although we never had a good vaccinal product for AIDS. But this had to do with engagement, with community engagement requirement. In the TB world, it's different. In the HIV world, the knowledge was built together, and the first responses to AIDS were from the civil society. That made the entire difference. When we step into TB, it's the medical world. It's the medical knowledge, it's the scientific language. And the advocates have to deal with that. I mean, they don't have the same skills. They don't do that for business. So that's the reality that people have to understand. And so we have to create that, but we have to give the communities the proper conditions to do. So we have to accelerate the way we engage community and change the way we do work, because it has not been very, how to say, successful, I would say. But let's see things like it is. There is a huge progress in the community engagement, and the WHO itself, the Global TB Program, have been impressing a strong acceleration of this. And I would say also, Matteo, that the rapid communications are extremely useful. I would say even popular. People use that a lot. Because why? Because it's simplified. You have a 2-3 pager informations that helps people and guide people, because people cannot go through the entire guidelines. I mean, this is not realistic. We have to translate also for frontline healthcare workers, because the governments don't do that. And language is a barrier. I would like to remind that the knowledge sharing platform is still not available in other languages rather than English. So the empire of the English language will continue. If you want to have a contribution from the Francophone world, from the Spanish speaking, from the Portuguese, the Lusophone world, from the Russian speaking, the Chinese, it's crucial that it's available in other languages as well. So we have to do a lot of work, but we are progressing. That's the good point.
Thank you.
Sorry
indeed.
for being so passionate.
No, indeed progressing, but of course room for improvement, including on more translations, getting more people on board in capacity building. So all taken on board. We'd like to now take another question. This one is from Gilles Cesari. I'm just trying to pull it up on, so could you please specify which tools, both for screening and diagnostics, are the easiest to use by community-led organizations or at community level? So for this, I'd like to start maybe with Saskia, if you could speak on screening, Nazir on diagnostics, and then I'd like to call on Dennis Falzon to add as well.
Yes, thanks very much for that question. First, screening at community level, of course, symptom screening is still sort of the easiest test to conduct at a sort of big scale, and it can be done very fast, and no sort of skilled expertise is needed, but training. So that's good, but then there are still issues with sensitivity and specificity of symptom screening. So other tests have also been successfully conducted in community-wide screening. For example, those MWRDs, of course, then there might be issue with cost, but it's very possible to collect sputum samples. And increasingly for chest X-ray, there's a lot of development going on with the development of like ultra portable chest X-ray equipment. So even chest X-ray is not limited anymore to be conducted in a health center, and chest X-ray can be taken to the community to be conducted locally, especially in combination with the digital X-ray and CAD. So it's always a balance between sort of pragmatic and feasibility questions, as well as sensitivity and specificity of the test, and of course the cost, and then the choice of your program model. Are you going to go from house to house? Are you having a sort of community-based event, etc.? So that's that for screening. Thanks.
Okay, thank you very much. Nazir, over to you, please.
Yes, I think what Saskia said is perfect. I mean, essentially, the same principles apply. Obviously, the cost qualitative aspects that need to be factored in. In terms of community testing, I think the two technologies that are relevant, obviously, is a point-of-care test, and the only one we have is LAM. Unfortunately, the performance is very restricted in terms of the population group needs to work well. So again, that really is limited to people living with HIV and obviously symptomatic people or people with advanced disease. But in terms of, I mean, the best tests for TB by and large are the molecular tests, and that includes the expert and the other MWRGs. I think in terms of a community setting, obviously you want sort of battery operated technologies. So I think here, I think TrueNet obviously is a battery-based technology that provides that field readiness in some ways. The expert has come up with the Edge. I mean, the Omni is not coming to market, but they have an Edge, which is a single module that can be deployed in communities, and that's battery operated. But I think irrespective of, in the community, the prevalence of TB is relatively low compared to what you find in sort of passive case finding where symptomatic people are appearing. So it goes back again to the screening strategies, right? So Saskia's points about the screening really determines how cost effective the approach is and the technologies that you use. But I think things can be done, and we've seen people with going around with fans, etc., with these technologies on board, going into communities. But I think that needs to be carefully thought, but doable. Thanks.
Thank you so much, Nazir and Saskia. You've both covered it all. So let's move to the next question, and we have with us, one of the questions is from Lindsay McKenna from Treatment Action Group, or TAG. Lindsay, would you like to ask your question live, please?
Yeah, thank you so much. I just put a question or more of a comment in the chat about, how I think there has been a lot of great progress and work, and Ezio mentioned this, to make more space for community and civil society on the GDGs. And I think my comment is about kind of the next step and how to make sure that the community and civil society representatives who are invited to the GDGs really feel capacitated and ready to contribute during the meetings. Anyone who has sat in on these meetings know that there's a lot of data presented. It's very technical. There are kind of research terms that are not common knowledge and take some time to understand. What's an odds ratio? What does it mean if it's, above a certain number versus below? What's a confidence interval? What does it mean when that crosses a certain number? So I think these are things that obviously, don't come naturally to many community and civil society members who are not trained in research. And so I think we need to take extra time to kind of increase the literacy around those things, and in a very applied way to the GDGs, and to prep community members and civil society reps. You're going to see, in this treatment guideline, the data presented, and the main number to look at is, X, and the confidence interval matters for this reason. And that way they can look at the data for themselves and feel like they're able to contribute in the same way that the scientists are. And so I just think, a lot of the onboarding ahead of guidelines meetings currently is very focused on process. And I think it needs to go to another place where it's focused on kind of the elements and terminology and interpretations of the science that community and civil society would need to be able to really, speak up at meetings and feel less at a disadvantage. And as Ezio said, like more not embarrassed that they're going to be looked at for misinterpreting something in a way by the scientists in the room. So I just wanted to put a plug for taking that to the next step. We have seats for community and civil society, and now how can we make sure that they're able to fully fill those seats and participate in the meetings? Thank you.
Thank you so much for that, Lindsay. I'll turn to Dr. Matteo Zinio to perhaps go first.
Yeah, thank you, Lindsay. I think this is really an excellent question. It's a really, I would say, the key question that we have all the time here when we brainstorm internally and think about composition of GDGs, membership of GDGs. We have this issue in mind, and we often end up sort of inviting, I'm not saying the same representatives of civil society, but the group is really restricted because we know very well that many times these discussions are really, very technical, and we want someone who is comfortable and able to contribute. So this is really a major issue that we are seeing. We are trying to tackle it, I would say, in one way, which is that we are inviting as observer an additional member or representative of civil society, not in a membership sort of function, but as an observer, so that there could be some peer-to-peer sort of learning, and the observer works with the full member, I would say, to try to learn how to interact in this discussion. We have done it within a few GDGs, particularly diagnostics, I would say. But I mean, if you think this is useful, we can establish this as a routine. We say every time we have a GDG, we have, in addition to the members, we can have 1 or 2 observers. That is one thing, but I don't know if that is enough. Probably is not enough. And we see that it takes really time for people to pick up knowledge, to be able to contribute. The other point that we have been discussing, I think, with Ezio and with Blessy as part of the WHO task force on civil society task force, was to try organize sort of some webinars with methodologists. This cannot be done, for one GDG specific. There will be like maybe general webinars that we can try to organize with you to go through the proceedings of a GDG, and then of course we have to invite our methodologists to help us. Now, to answer some of the questions that you put in the chat, like what is the odds ratio, what is the p-value, there is a bit, it's an additional step, and I'm not sure we have the capacity at the moment to basically fulfill that, that knowledge gap. But we are open to discuss that.
Yeah, if I may, so I will discuss, Matteo. I think that we have to change the wheel while the car is running. So that's our challenge. We have to do that because the GDGs cannot stop. We have to do the GDGs. We have to progress. So I think the point that Lindsay was bringing is that we have to improve the consultation with a certain advance for the communities to see if we have community representatives which are qualified, better qualified, or have skills or have been engaged in follow-up of studies to participate in the GDGs. This is very relevant. But the other point is that we have to build the capacities, and this only happens with time. This only happens with investment, which is non-existent in the most of the cases. People tend to think that the community participation is enough being based on a volunteer base, and that people don't, the education that you are mentioning, it requires investment, requires time, and there is none. This doesn't exist, so we have to create the mechanism, and WHO should champion this also with the sponsors, that that there is funding to build and to establish independent and cabs, that we have mechanisms of community participation and research literacy, because this, with some EPI information, we have to, for example, simple things, we have to give classes on PICO questions. We have done this in Brazil, but we have to do that on a permanent basis, so to learn people, to teach people. So this requires investment, and we don't have that. We cannot think that we will solve things on webinars. This has to be built. These capacities only can be built with specialists, like participating and creating capacity. It's education. Education takes time. So that's my point of view.
Thank you, Ezio. Thank you, Lindsay and Matteo, and all our panelists. Thank you for all of these questions. We are at time. Thank you for all the suggestions, and we will, if you have further questions, we have put our email on the chat. Please do send us any further questions or clarifications you have. Now, before we wrap up, I know we are a little over, but we need your time for 2 more minutes. We would like to hear from you very quickly. because as various presenters and even Ezio himself has said, it's going to be all hands on deck. We need, it's not, and as Matteo and Teresa and others have said, it's not WHO that's going to do this alone. We need your inputs. So could you please share with us your suggestions on how you can join us in supporting rapid uptake of WHO guidelines in countries? So if you could go take a quick minute to go back again on Slido, use your phone to scan the QR code, or go to slido.com and type in the password #info_CS. We would very much like to hear your suggestions. We will keep this poll open so that we can hear from you on what your suggestions are going ahead. So please do log in, leave us your suggestions, leave us your offers or what you think would be very helpful. So leaving that poll online for your inputs. So I'd now like to turn quickly to Dr. Teresa Kasaeva to say a few words. Thanks again to all the panelists, but Dr. Kasaeva, if you'd like to say a few words, and then I'll give the floor to Matteo. Over to you, Teresa.
So thank you very much, Monica. It was a very interesting discussion. I listened carefully to your questions, to the responses. I think that we all in agreement that it's mutually useful, and we should continue this discussion. Important to hear your concern, your questions, your requests, and also our feedback. We should continue, of course, and we've heard your request. We will continue improving your engagement, giving more opportunity. But in the same time, once again, I would like to pay your attention that we should jointly do our best to make the uptake of the guidelines faster, because they will definitely improve treatment outcomes and diagnostics and the general situation for people with TB. During current COVID pandemic is becoming even more critical. So that's why this is my request, what we can do, because I'm comparing now, looking at the uptake of the COVID related recommendations. They've been developed faster and sometimes not going through this detailed and very carefully, properly organized process. And the uptake happens immediately. But in our case, all these evidence-based solid recommendations are not uptaken for the years. How to make it, and we can see some examples in the countries. We had recently NTB summit. We've seen that, for example, in Ukraine, there have been made high-level decision to uptake WHO recommendations as they are, without adaptation and a long country-specific process. This is good practice, and let's try to learn from each other to work closely and make them available. Thank you once again for your attentions. Your comments and proposals are extremely important for us. We will continue working and share this knowledge, invest in capacity building through different ways, including through the webinars like today. Please remain healthy and safe.
Thank you very much, Teresa. Over to you, Matteo, for just a few words.
I just want to thank everyone for staying with us. Thank to all those who have actively participated. Thank to Ezio, and of course to all those who have contributed. Thanks to Monica for the great sharing and all the team behind the scene. I wish you a great sort of end of year break, hopefully, and hope to see you next year for the next webinar. Bye-bye.
Happy holidays to everyone. Bye-bye.
Bye, everyone.